And next I invite Dr. Neethu Latiff, Senior Consultant from Giridhara Institute, for her talk on challenges in treatment of uveitis.
Thank you, Dr. Risha ma'am. So I'll be talking on challenges in treatment of uveitis case scenario. So case 1, it's a 43-year-old female with blurring of vision in the left eye more than the right. Since 3 weeks, status post cataract surgery in both eyes 14 years back, and the vision in refractions as follows. And as you can see in the right eye, the IOL is partly displaced into the anterior chamber along with the bag. And also both eyes, we could make out the fine stellate KPs distributed all over the cornea, and these sort of nodules in the pupillary margin, and there were deposits on the IOL surface. Fundus, the media was hazy due to the wet haze, and there were floaters, and the OCT macula was within normal limits in both the eyes. So this is a case of bilateral Fuchs uveitis, probably could be an acute exacerbation of Fuchs uveitis. I started with a short course of topical steroid in this patient, and her BCVA improved in 1 month's time. So the message here is no one is allowed to die or go blind without a trial of steroids. Even though we know that steroid has a very limited role in Fuchs uveitis, in such a case scenario, I don't think it's a harm to try a course of topical steroids under careful monitoring of the intraocular pressures. So case 2, 54-year-old male patient with gradual loss of vision since 4 months. He's a non-case of alcoholic cirrhosis, diabetes mellitus, and history of skin rash 1 month ago on his left arm. Fundus examination, there was bilateral retinal vasculitis, and there was a retinitis patch inferior to the disc in the right eye, and also in the infratemporal arcade in the left eye. So we did a fundus fluorescent angiography. There was diffuse capillary leak with fern-like pattern and cystoid macular edema. OCT showing cystoid macular edema in both the eyes. So the diagnosis is not so challenging because it's actually B51 positive Behçet's disease. We took a dermatologist opinion and a rheumatologist opinion. So the dermatologist said that it is a herpes zoster infection which has happened 1 month ago. So here I was a little hesitant to start with a proper course of treatment because of his systemic condition. So we had a careful discussion with the rheumatologist, made sure that the patient was properly counseled, gave him the option of the treatment, and then started with the IVMP course, and explained clearly the probable chances of herpes zoster reactivation and his systemic condition. So, then careful monitoring was done each day after IVMP. And then, but on treatment, he developed variceal bleed and esophageal candidiasis, and we had to stop all the treatment. And once he was systemically stable, we took the gastroenterologist opinion and then restarted on a lower dose of steroid and immunosuppressive therapy. And at the end of 3 months, his vision is maintained to 6.6 N6, and systemically also he's doing well. So the message here is in any case of associated systemic disease, do go for a multidisciplinary approach rather than treating the patient on your own. So case 3, it's a 47-year-old female with sudden onset redness and pain. And as you can see, it is a bilateral exudative retinal detachment with RP undulations and possibacillary detachment. No doubt it's a case of VKH, treated with IVMP, oral steroids, and IMT. After 1 year of treatment with maximum dose of IMT and oral steroid, the patient had a vision drop in the left eye. As you can see in the fundus photo, it's a sunset glow fundus, and in the right eye, there's a subretinal fibrosis, and in the left eye, there is a peripapillary CNVM. So then we advised the patient to go for intravitreal injections. But then the patient was a poor patient, she couldn't afford, but still we convinced her, managed her to get the injections done. So, but in repeated Avastin injections, 6 injections were given, but still the CNVM was not under control. And the patient cannot afford any other intravitreal or biologics. So what to do this patient? So we then thought, why don't we give her intravitreal triamcinolone? Luckily, she was not a steroid responder. And we gave 2 mg with Avastin, and then the vision maintained to 636 N36, stable even after 3 months of intravitreal injection. So the message here is the good physician treats the disease, the great physician treats the patient who has the disease, by Sir William Osler. So case 4, a 43-year-old doctor, non-case of sacroiliitis under rheumatologist care, She had recurrent episodes of non-granulomatous anterior uveitis in the left eye, treated with topicals. She has raised intraocular pressure noted after starting topicals. Repeated episodes of anterior uveitis in next 7 months. Query the cause. May not be due to the back pain because it is not alternating in both the eyes, sticking on only to the left eye. May not be a steroid responder. Could it be a hypertensive iridocyclitis? No features of viral uveitis in the eye. ACTAP was done, PCR was positive for CMV, started on antiviral therapy and no recurrences so far. So the message here is revisit your diagnosis whenever you think that something is not going in the right way. Case 5, a 15-year-old girl with diminished vision in the right eye since a month, denies any systemic illness, and her FFA, the right eye, showed a diffuse capillary leak, fern-like pattern. Left eye was normal and a very large cystoid macular edema. And the autofluorescence also, you can make out the cystoid macular edema. So she was treated with IVMP, biologics, adalimumab, and maintained on a low dose of methotrexate. Vision maintained from counting fingers to 615. But her complaint was that she is still perceiving a ring-like defect. So then I repeated the fundus fluorescent angiography. But still, in the autofluorescence, you can see this ring-like defect. And also the OCT showing a ellipsoid layer discontinuity. So I probably don't know the cause behind it. I think it's probably because of the resolving CME, but I have not seen a resolving CME with a ring-like appearance in the autofluorescence. And case 6, a 43-year-old female with left eye sudden drop in vision on treatment for SLE. She was treated by the rheumatologist with biologics. Her blood CMV titers were high, and she had a CMV retinitis. So she received 4 doses of intravitreal ganciclovir elsewhere, also on systemic ganciclovir, patient responding well to treatment. On subsequent follow-up, I noticed RP mottling in the mid-periphery, which is picked up in the autofluorescence. Did a ERG, the ERG showing grossly reduced amplitude for scotopic and photopic responses. So I don't know what is the diagnosis, but still I suspect a retinal toxicity due to the intravitreal ganciclovir. So to conclude with, listen to your patient. He's telling you the diagnosis. Do always go for a multidisciplinary approach in cases of uveitis. Revisit your diagnosis whenever you think that something is not going in the right way. Always be vigilant and modify yourself depending on the clinical signs. Thank you.
Thank you, Neethu. The take-home message of this session is to become a good uvea specialist, you have to be a good ophthalmologist as well as a good physician. You have to talk to the patient, you have to examine the patient again and again, and discuss the treatment options and revise your treatment. Thank you.